The following program on PBS Fort Wayne is made possible in part by...
We all experience tough times. Behavioral and emotional health issues can cast a shadow on everyday life, creating problems that may get worse without help. Let Park Center be your partner in recovery, helping you to find options to feel and do better.
And good evening. Thank you so much for watching HealthLine on PBS Fort Wayne. I'm your host, Mark Evans. We're going to be talking about a very important topic, especially these days, and that is, of course, suicide. And we're going to understand suicide and also understand the risk and theory of it all. Delightful person I was talking to right before the show, Dr. Charity Smith, is my special guest tonight. You've been here before.
I have, yeah.
You've actually talked to Jennifer Blomquist, the other host of HealthLine. But we wanted to bring you back because this seems to be a prevalent topic these days, especially with everything that's going on, and I'm sure you're seeing that yourself. But as a mental health counselor, and you also studied thanatology. Am I pronouncing that correctly?
You are.
Okay.
So thanatology is the study of death, dying, and bereavement. And so we look at death and dying from a psychological perspective and a sociological perspective to better understand its impact in our day-to-day life, how we handle death, how we talk about death.
And that's also very important. I see how all this ties in. And of course, we're going to open our phone lines for anybody who would like to call on behalf of themselves or someone that they love. So the telephone number, of course, is going to be right there on that one. That screen, 866-969-2720. Please call throughout the program. We'll be here for a whole half hour. We don't stop down for any commercials because we are public television, and we'd love to talk to you. Well, let's go ahead and get started with a couple of things. I prefaced the show about talking about how prevalent this topic is, but why is it such an important topic to talk about?
So it's something so suicide in the U.S. is the 10th leading cause of death, and yet it is a mode of death that when we talk about it, or when really we don't talk about it, it's in these very hushed tones. And so you might hear somebody kind of whisper like, oh, so-and-so died by suicide, but no one really talks about it openly. So if we don't talk about it openly, we really don't give an opportunity for folks who are considering dying by suicide to really talk about how they feel. And it's also a mode of death, again, like it's incredibly stigmatized. And so when we talk about death, even the language we use around suicide really brings kind of more shame to it than it does invite a conversation. So if you think about when we say that somebody's died by suicide, instead of saying died by suicide, we say they committed suicide. Think about other things we commit. We commit crimes, we commit sins. So if we hear that language and we're somebody who's thinking about suicide, there's already this sort of shame-laden idea around suicide. If we can demystify it and we can take some of that stigma off, we create a world where not only can people feel more open to talk about it and talk about feelings of wanting to die by suicide, we can also create a world where people are willing to hear that and talk about those things with somebody who's struggling, and they can be a part of that conversation to help. And
the World Health Organization estimates, and the United States isn't alone in this, but approximately 1 million people die each year from suicide worldwide. And are we seeing an uptick in that these days?
Absolutely. So right now, the national, it's the Suicide Prevention Lifeline. They're seeing an absolute insurge or influx of calls right now. Considering the pandemic and what that does to us, this kind of idea of quarantine, one of the risk factors that we'll talk about in a bit is social connection or the lack thereof. And so what's happening with the pandemic is that we are all being pushed apart from one another at the same time that in society we're also overly connected through other media. So we don't have that interaction that keeps us feeling safe and supported. We don't have a day-to-day, face-to-face necessarily with someone where we can open up about how we're feeling. It's also really easy to start to feel like everything's kind of falling apart. Like the world does seem to be in a great deal of upheaval right now. And if we internalize all that and don't have anywhere to put it, we start to feel like maybe it's only going to get worse, or maybe I can't get out of this, or maybe it's not worth it anymore.
Right.
Yeah.
Well, can we break that down in age categories? Where are we seeing this the most?
Absolutely. So there's two ways to look at that, really. So the highest rate of suicide is among those 45 to 64. So by numbers, white men particularly, from 45 to 64, die by suicide more than any other group. However, if we look at folks who are 15 to 24, suicide is the second leading cause of death for people 15 to 24. For those higher up, I think from 45 to 60 or 55 or somewhere in there. Don't quote me. But it's the fourth leading cause of death, and then it gets further up the line the older folks get. But for young people, it's 15 to 24.
Well,
it's the second leading cause for people 15 to 24.
and let's break that down even more. Let's just drill that down. Let's start with the younger age category, 15 to 24. What types of pressures or things are going to motivate them to even think about suicide?
Absolutely. I'm so glad you brought that up. It's actually one of, when we talk about risk factors, and I think we have a slide for the risk factors too, and I did mark on their demographics because it's important to consider demographics. If we think about what it means to be 15 to 24, that is really the time we are defining our identity in such a big way.
And it's such a threshold for anybody to commit suicide, but especially young people, because they're just getting started. And you got to wonder, what is so bad?
Think of all the things that happen in that age bracket, though. There's a very big kind of coming of age and the pressures of who am I, and what does that mean, and do I fit, and in what ways don't I fit, and can I be okay with that, or is that too much for me? And then when we move out of, so it's sort of two different age ranges there, right? So 15 to 24 is a pretty broad span, but if we break that down to like 15 to 18, then 18 to 24, 19 to 24, you're talking about the pressures of high school and then the pressures of launching from high school. That doesn't even speak to what else you may have going on in your personal life, in your home life, your own mental health needs. That doesn't even speak to that. That's just identity alone. And so when we think of that, and that's some of the other risk factors too across all the ages, is if you have existing mental health problems, that may be a risk factor for suicide.
True.
If you have a family history of mental health issues, that may be a risk factor for suicide. If someone you know has died by suicide, a peer, a family member, that increases risk. Substance use issues, things that you would think would kind of deplete you a little bit anyway, leave your resources depleted, would create a greater risk.
Well, and then we go to the 45 to 64. Would financial pressure have anything to do with that?
Think of what it means to be a 64-year-old white man.
Okay, I'm almost there myself.
Okay, so I'll assess you later, but
I think we're fine.
I think we're good. Okay.
I'm glad to be here.
Okay.
We've got a lot to live for.
So at 64, or as we get later into life, there is this idea of this really big identity shift. And so we're moving into a stage of life where we start to question, like, what is my role? Excuse me. What is my role? What is my place here? Do I still fit that role? Am I still relevant? Becomes a really important question because we're kind of getting aged out in a society that very much values youth and puts a monetary value on youth. You get paid more in certain age brackets.
True.
So to be at that age where you're starting to shift and say, what is my role? And I'm kind of handing that mantle off to a younger generation. Am I becoming obsolete? Do I still matter? And if we're able to find meaning later in life, it's less of an issue. But if we really struggle with that and don't share that struggle with anyone, it becomes a more prominent risk factor.
And I'm surprised too that, we've got that core of 45 to 64 in that age group. I would think that after someone retires, and all the kids are out of the nest and so forth, that it would shift to maybe an older category. How are the geriatrics doing with this?
So the next down in the ranks, we've got 45 to 64, and then we've got 65 plus is the next highest age range for the suicide rate. Okay. And then beneath that is the 20-somethings, 30-somethings, and beneath that the 15 to 24. In a geriatric population, it's possible that we would see more suicides, but then you have to figure also the causes of death become more variable. And so we're also seeing deaths by, heart disease or cancer or a heart attack, something more or either chronic or acute. So we still see that. That's a very important age range to pay attention to, particularly because that age range has some different challenges than others. So you think about 65 and over. One of my dearest friends in the world is 95, almost 96 years old. He has literally had every friend of his die at this point.
Oh, yeah.
And so there's a bereavement overload that happens after a while where you feel like, I can't take all the loss. I can't really establish where do I fit when I no longer have peers. So there's a different challenge there. And then conversely, going back to that 15 to 24, one of the challenges in that age group, really when you're figuring out identity and a population I really want to identify as having a higher risk, is LGBT youth. Significantly higher suicide rates among LGBT youth, because when you're figuring out identity and you realize you don't quite fit in with your peers, and you may not even be, it may not be something that your family values or approves of, or you may be being shamed by all these outside sources, it really increases your risk. So there's all these interesting risk factors at different points in the lifespan.
Well, with that category of youth, obviously since mankind's been around, there have been LGBT people. So are we seeing an uptick in it now versus years ago when people kept it more closeted, or is it about the same?
So it's really hard to say, right? So automatically suicide risk or suicide, excuse me, suicide statistics are difficult to kind of quantify because not every death can readily be identified as a suicide.
Okay.
So we already, and it's also it's a very hush-hush kind of taboo kind of death. People
Right.
cover that up. They try and make it look like something else. They don't want people to know their loved one died by suicide.
Right.
So the stats are a little bit off to begin with. They're not really clear to begin with. So it's hard to know, really, how many LGBT folks were dying then by suicide because if they're not outed, if they're not have not come out themselves,
That's true.
we don't really know.
Yeah.
Right.
And right now it's just a big old wide open world. We've got, of course, the bullying going on.
Yes,
and
huge factor right there.
shunning by families and the churches and so forth. So yeah, I can see how that all ties in. Well, let's talk about what's being done. How can the research on suicide help a lay person, a common person, if you will, non-degreed person, to better understand or to help identify that risk?
So the first person I look to when I talk about, because I also teach on suicide when school's in, when we're not in COVID. First thing I talk about is Edwin Schneidman. He's kind of the granddaddy of all suicidology. So Edwin Schneidman was the first one who even coined the term suicidology, who really started researching this en masse and creating terms that we can use to help people better understand it. And Edwin Schneidman came up with these 10 commonalities of suicide. And the 10 commonalities, I think we have a slide for that one too, where I only highlighted 3, but there's obviously 7 more. But the 10 commonalities he researched extensively, people that have either attempted suicide or have completed suicide and left a note with some sort of information to help explain the suicide. And from that, he drew these 10 commonalities, and you saw that it's not really about trying to die so much as it is these commonalities, these common pieces. And the first one I have on there is the common purpose of suicide is to seek a solution. And you'll notice in that it doesn't say the common purpose of suicide is to die. It's that there is a problem that feels so pressing and the suffering is so great, it feels like that is the solution.
True, I can see that. Yeah.
So it's less about trying to leave this life as it is trying to leave the pain you're currently experiencing.
Right.
And that's why it's a preventable form of death, right? Like we're able to intervene when we can intervene. We're able to help ease that pain and therefore pull away from that idea of suicide. The second one I have on there, and this is directly a Schneidman term, he coined the term psych ache. And so it is this unremitting psychological pain. And it's not, I've had a bad day. It's not a couple Eeyore days. It's truly this unremitting, gut-wrenching, kind of center of your chest cave-in kind of feeling, where you want to get away from this significant source of pain. And it's not about not seeing the joy in your life anymore. It's that the pain has become so overwhelming that the joy has lost the joy. Yeah. The third that I highlight is this idea of constriction. And when Simon talks about constriction, it's really about this idea of all of our stress and all of our pressures press in on us so tightly that it creates almost a tunnel vision. So it really winnows away all these other options for how can I help myself. And at the end of that tunnel, the light we see becomes suicide. It feels like the only option left.
Now, is it considered the only option left when, well, I can see it both ways.
Okay.
I mean, you can be surrounded by friends and family who constantly tell you that you matter, they care
Right.
about you, they love you. And then you have the people who are really lonely, who have either by their own choice to be isolated on their own, or
Right.
they don't want to be involved and don't want people to change their mind. But is it, during the therapy and your counseling sessions, is it ever brought up about how you may be affecting others if you do this?
So it would really depend, because for that person, they're seeing their life as more of a burden. They're seeing their life as being more of a problem. That's actually something that's talked about in Thomas Joiner's interpersonal model, interpersonal theory of suicide, which we also have a graphic for too. It's a trifold model where people feel like they are a burden. So this thwarted belongingness and perceived burdensomeness that we see on there, thwarted belongingness means I don't really fit, I don't belong, nobody really wants me anyway. And perceived burdensomeness means I'm a weight on this family. I'm not a help, I'm a hindrance. And so rather than it being this idea of suicide being the selfish act that hurts all of us left behind, for that person, they really feel like they're doing something good for us. And so in a situation like that, I would really want to focus on what it is that causes that thinking. What's going on right now? What's that psych ache? What's the core of it? How do we treat that and work our way out to including others in and understanding our impact and not necessarily our impact, but our role within our system, how important our role is. Now, we're not a burden, we're an important piece of our family system.
Are most suicide attempts knee-jerk reactions, or are they pretty well thought out in advance?
I will say that it's not an impulsive act. And so for somebody to die by suicide, it's not because they thought of it that moment and said, okay, I'm going to go do this right now. There's been a previous thought. The length of time that thought occurs for somebody is different from person to person by far. Mm-hmm. It's very much variable.
Okay. All right. And what do you think if we, what do we do, I should say, if we think someone we care about shares with us that actually thinking about suicide? What are the things that we need to do, like right now?
So the big thing we need to do is realize that this is a person we care about, and we've talked to them before. We've had conversations with them before. So we want to be able to have a conversation. But to have a conversation, and a truly good conversation, means we have to be willing to listen. Mm-hmm. And it is a very difficult topic for many people to talk about. So to have a conversation and be able truly to be an empathic listener, we have to be considering where they are, what's going on for them. And we don't want to interject with things like, well, when I was in your position, or, well, when it happened to me, here's what I did. Or even saying things like, oh, I totally understand what that's like. I always encourage people, instead of I understand, to say I hear you, because we don't really know what it's like. Mm-hmm. And so we first want to be able to listen. We want to be able to have a conversation and give them the room to speak and to share with us. And from there, we want to try and help get them to where they need to go to get that help. We want to try and steer them to where they can go to get the help that we as a layperson don't necessarily need to be providing. The one thing, too, that I really encourage for people, the first number we ever learn is 911. Mm-hmm. And the second thing we learn about 911 is to never call it. That is the message we get as children, because obviously kindergarten children, we don't want them learning, oh, I learned a new number today, let me show you.
Right.
Right. So as adults, there are people that are still really fearful of calling 911. If you are in a situation where that feels appropriate, absolutely do that. That's okay to do.
Okay, very good. We do have a call coming in, as a matter of fact, as we speak. April, who prefers to be offline, so she doesn't want to be on the air, and that's perfectly fine. In fact, they were trying to load up the question. I might be rushing our poor graphics person, our phone answerer, probably a little too much. But we'll go ahead and get that taken care of, as we know a call is coming in.
Sure.
But when someone comes to you for help, mm-hmm. as a mental health counselor, saying, I've got these feelings of suicide, I don't know what to do, I just want to end it all. What is the first step you take? What are the first questions you will ask that person?
How did we get right here today?
I see.
Where are we right now? What's going on? Because that is always the most important question. Even if this thought of suicide has been progressive through a lifetime, what's going on right now? And then for me, in my particular role, and I think it's okay too, if we're a layperson, to ask, okay, are you thinking of killing yourself right now? Do you have access to means? Do you have a plan? Because access to means absolutely increases our risk. Yeah. We want to assess even for things like sobriety, because if somebody is drinking or is on a substance, they may be at a greater risk for suicide acutely in that moment. So I want to really get the lay of the land, see where they are, and what got us to this particular space we're in today.
Yeah, okay. Well, that makes sense. Mm-hmm. That's very logical. And as I mentioned, April called in and she says, are people who are feeling suicidal due to medication side effects treated differently from those feelings are non-medicated originated?
So treated differently in terms of how I would treat and work with somebody, not so much. Obviously, we want to identify if there is a medication. There are certain medications that significantly increase the risk of suicide, and hopefully doctors are letting people know when they put people on these medications that these are risks. But so in that situation, we definitely want to first say, okay, there's a reason we have an acute risk right now. But then we also want to address what happened when you had those thoughts. What was it like for you, particularly if it's somebody who's never been suicidal and suddenly the medication is bringing that on? What's happening for you right now feeling that way? That's got to be really scary, to feel these feelings that feel very foreign.
True.
We still want to keep an eye on the situation. We still want to monitor. We want to make sure people are getting to a higher level of care to keep them safe if need be, because suicide is suicide no matter how you cut it.
Yeah, exactly.
Right.
Exactly. Well, if you're just joining us, we're talking to Dr. Charity Smith, who's a mental health counselor, and our topic tonight, understanding suicide risk and theory. Some very interesting things she's brought to the table tonight. And while we're waiting for more calls to come in, the telephone number, of course, is on your screen. She'll be more than happy to address your concerns at 866-969-2720. But there's something I like to play once in a while on shows called Fact or Myth. Okay.
Lay it on me.
And actually, here are a few questions I'd like to ask you. Fact or myth? People who talk about suicide won't really do it.
Myth. 100%. So people that talk about suicide may do it and they may not. What's important is that we want to take all talk of suicide seriously. A great friend of mine gave me a wonderful piece of advice that I use with clients, which is if somebody talks about suicide, if somebody wants attention, you give it to them. Never make them up the ante. Never make them prove to you that they're serious. We want to take it all seriously.
Yeah, just the slightest, the littlest remote thought.
We want to latch on and say, okay, what do we need to do right
Let's
here with
take
this?
care of this right
Exactly.
now.
Yes.
All right, fact or myth? Anyone who tries to kill themselves must be insane.
Nope. So think about what it takes to get to a space. If we look at Joiner's model again, thwarted belongingness, perceived burdensomeness. Who among us has not felt at some point like we were a burden to a friend, a family member, a peer group? Who among us has not felt like we didn't quite fit? When those two things come together, we automatically have, not automatically, it is very possible that we have an increased risk of suicide because we don't feel like we have a place to be. And that's not crazy. That's a human response and a human feeling, and feeling so in that moment isolated or burdensome and needing to have somebody kind of reach in to help us.
True.
Yeah.
Well, that sounds very logical as well. Okay, one more, fact or myth. If someone is determined to kill themselves, nothing is going to stop them.
I am living proof that that is not true. So that is a large piece of my job on a fairly regular basis, particularly through COVID when things are so stressful and difficult for people. We can absolutely help. Does that mean we save everyone? No. I wish that we did. But it does mean that where there's a will, there's a way from the helpers too. We are able to help, we are able to reach in. And I think the key point there is that we don't want to wait until somebody reaches out for help. If we see things are going on, if we know that our loved one's not okay, or they're just different, or making some more off-color jokes that are more death-oriented, or starting to really pull away from us, we want to check in, we want to reach in and not wait for that cry for help.
Right,
Yeah.
right. Okay, and then another call just came in from Bays. He is preferring to be off the air, but he's asking, are there telltale signs to look out from people who may be considering suicide?
So that really goes to what we were just speaking about, of this idea of if someone starts to pull away, or if someone is making, more, death-related jokes, or talking more about death, or speaking more despairingly, is presenting as more hopeless or feeling more helpless. Social isolation is a big piece of that. So as people are really trying to remove themselves from the scene. But that being said, there are situations where we don't get a warning sign. There are situations where they didn't show us in some way. And so we want to be able to look for those things, but by not seeing it, not preventing that suicide, doesn't necessarily mean that we missed a sign. It's not really something that we've done wrong.
Okay. And now, people who die by suicide, are they people who are unwilling to seek help?
Absolutely not. So the challenging part I have not yet had a client personally die by suicide that I knew directly was a suicide. I have had some overdoses that I think were questionable in the long run. But those are clients that were absolutely seeking help and were absolutely seeking care. So it's not an unwillingness to seek care or a lack of seeking help. It's what happened in that moment that made suicide feel like the best option, help or no help.
And then talking about suicide, will that give someone the idea?
No, and that's such a common myth. I'm so glad you bring that up. So this idea that if we talk to somebody about suicide, that's going to make them suicidal is incredibly false. The reality is that person might be waiting for someone to ask them. So if I say, oftentimes, people will joke, if you ask someone if they're going to kill themselves, of course no one's going to say yes to that.
Right.
But plenty of people do, because they've been thinking about it and they're just waiting for someone to ask.
Yeah.
They want the conversation and they need the conversation. It's important. So that's why it's really, I love the idea of having this as a whole show today, because we need to reduce that fear around talking about it, and that fear that if I bring it up, maybe they'll think about it, maybe they weren't, I don't want to push them. We need to have those conversations. That's how we save people.
Exactly. Well, we have a couple of very important phone numbers and sources of help, and let's go ahead and talk about the, the help hotline?
So the Suicide Prevention Lifeline, it is a national hotline. It is 1-800-273-TALK, and I believe that is 8255 is what TALK represents.
It does.
Okay, good. So that is a national lifeline that is 24 hours a day. You can actually go onto their website, and there's also a chat option. They have a text hotline number. I believe it's 741-741, but I am not certain. I would definitely Google that first. And then there's also a local number that is through Parkview that I believe we have too.
Yes, there it is.
There we go, yes.
All right, that's 1-800-284-8439. That's 24 hours
yes, as well, absolutely.
What kind of people are you going to be talking to when you call?
People that are trained to hear that that fear, that pain, that struggle in your voice, people that are trained to help you to get to where you need to go. So I will disclose that when I was much younger, I actually used the Suicide Prevention Lifeline in my late teens. And it was one of the most rewarding conversations I think I've ever had, because someone was willing to talk to me about suicide and they used the word suicide. And it was, I don't want to say exciting, but it was exciting to hear that somebody spoke the language I was feeling. So these are people that have a trained ear, and also a lot of times it's people that have been through some struggle themselves and can really show some deep empathy.
Okay, we have about 30 seconds left, and this is your time. Of course, the whole show's been your time, and it's been a great show. But some takeaways from this program.
The two big takeaways that I actually give to my students all the time is, one, suicide can happen to absolutely anyone. So even though we have these demographic variables, that does not mean we pigeonhole that idea that suicide can only happen to a subset of people. It can happen to anyone. And two, again, that idea of if somebody wants attention, we give it to them. We take all talk of suicide seriously.
All right, very good. And I find this program very important because I've not only had a friend, but also a couple of relatives who have actually gone through the whole suicide thing.
Yeah.
So thank you so much for being here.
Absolutely.
And we must have you back.
I would love to.
Dr. Charity Smith, mental health counselor, and we thank her for being here. We're going to be back next week with another fine show, of course, here on HealthLine on PBS Fort Wayne. Thank you very much for watching and participating in our program tonight. Good night and good health.
The preceding program on PBS Fort Wayne was made possible in part by
You don't need to be alone in your journey toward mental health recovery. Park Center staff will partner with you, helping you in your efforts to lead a more hopeful and satisfying life. Let Park Center be your partner in recovery